And last but not the least, I'll invite my friend Eric Mertens to come and share his experience as well.
First of all, I would like to thank Medicontur for inviting me to give this talk and this lunch symposium. Actually, I'm going to elaborate a little bit more after Satish's brilliant presentation of the AddOn and how to bring actually patients into their visual comfort zone. And what do I mean with that? This is my financial disclosure for this talk. So what is our mission as refractive or cataract surgeons? Is to have plenty of happy patients. Whether they have 20/20 or 20/30, actually that doesn't matter, but they need to be happy. And that is what we want to see in our waiting rooms. Now the reality is that a lot of our patients still need glasses post-surgery, and especially post-refractive surgery before when you are going to explant the lens. Now, when you look at cataract surgery itself, more than 20 million cases are done each year, and only 1 million of them are implanted with a premium IOL for now. And 19 million are implanted with monofocals, which of 11.4 million of them, they still feel they're out of their visual comfort zone, even with a monofocal implantation. A lot of patients are not really satisfied what we have done with them. So target refraction achievement is extremely important. Oliver Findle published this in the Journal of Cataract Refractive Surgery 2015, saying that 20 to 30% you get a refractive surprise of more than 1 diopter after cataract surgery. Another nice literature is by Cook in the JCRS. 75.1% were within half a diopter range. Still 25% are outside the half a diopter range, and with premium IOLs, this is not a good result. Now, what are our management options when we have to deal with these patients? Of course, we can give them spectacles or contact lenses, but that was sometimes the goal, not wearing them. We can do laser refractive surgery, we can do PRK, LASIK, SMILE, or we can do an IOL exchange. And we all know that this can induce a lot of complications, capsule rupture, and so on. So these are all things you have to consider. And after in YAC capsulotomy, this becomes, of course, much more difficult. The fourth solution is the topic of my talk. So the AddOn lenses, they are specifically designed for ciliary sulcus implantation. Now, this is the main indication in my practice is this lens, and I will tell you why. It's correct for ametropia after cataract surgery, so the retrofit approach, and also presbyopia correction with the trifocal design, as was shown also already by Satish. So when people have monofocal IOL, sometimes it happens that, oh, I did not know that I would be so handicapped when in daily life, my dashboard, playing cards with friends, I always need glasses. So I need actually, after my monofocal IOL implantation, I want for a correction for near as well. So the retrofit approach works very well. I will show you this. The characteristics of the lens were very well pointed out by Satish. I will not elaborate on them. So this is how you put in the lens in the cartridge. So actually the convex side towards you. You tuck the haptics nicely into the cartridge before you close it. Then check it on a microscope whether there are no haptics in the wings actually of your cartridge. Second video I want to show you is this one. This is a post-YAC capsulotomy case with a multifocal IOL in place. And when you do that in the first time, you will be afraid, of course, because you do not want to end that first lens into the vitreous. So what I do is, with a second instrument, I go under the optic of the AddOn lens to have no downward pressure, and then slowly injecting it. You can see I put some viscoelastic under the iris here and there to easily put the haptics under the iris. Then I go in between the first lens and the posterior to get rid of the OVD, and then this haptic is repositioned at the end with the IA in the end of the surgery. Now this is another example. This was a WIOL. This is a continuous focus IOL where we had a refractive surprise. And also here, what is the solution to explant this large lens is not impossible, but it's extremely difficult. So I went to the add-on approach, the retrofit approach. You do a 3-step corneal incision, as I can show you here. And then, again, using some viscoelastic here under the iris, there under the iris, just to make sure that the iris comes up so you can have easily the haptics gone into the sulcus. Second instrument through the paracentesis, and then the lens comes in. And here I'm not supporting inferior, on the inferior side, the add-on, because there is no capsulotomy done. And then I will tuck the haptics under the iris. So it actually is the same as what we do always, but this is a very peculiar or particular case. Why? I will show you right away. Putting the haptics here under the iris, okay. But then I saw something, and I hope you can see it. Here, something is going on in this corner. Hope you can see it right away. Actually, the haptics was folded up onto itself. So, and you can see it because it was not well centered. This lens centers very well. And at the end, I could put the haptic here nicely in the right position. I think you can see it here. That is not, it is folded onwards, and you can see it nicely. So go in and reposition that haptic. It's actually it's very easy, but you have to just pay attention to it. And you can see it here very easily because this lens is not centered. And all of our lenses with this approach are centered well. So you see it's very easy to reposition it. Can we go to the next slide, please? Is that, or I just wait until the end of the video and it will automatically go to the next, I hope. Or can you advance the slide? No, I cannot do it here. The second video. The second video, and then advance, because when I click, the video will restart. So implanting this lens is actually very easy. It takes a couple of minutes. So what are the main points here? Putting the lens nicely into the cartridge. Take care that the haptics are not in between the wings of the cartridge. By injecting the lens, in a normal case, just lift the iris a bit with your viscoelastic. Go in between the add-on lens and the lens which is already in the back to get rid of the OVD for avoiding pressure spikes. Satish mentioned that as well. And when you have a post-YAG capsulotomy case, just go with your second instrument under the add-on so there is no downward force. You're not applying force on the premium lens in the back, maybe rupturing more the posterior capsule. You do not want that. Now next slide, please. Yeah, if you can advance this one. Advance, yes, please. Okay, so after implantation of a secondary intraocular lens to correct residual refractive error after cataract surgery, this is a viable surgical option to correct it. This was published in Clinical Ophthalmology in 2017 by Gail Gunnarsson. This was these results. You see that the pre-op uncorrected visual acuity was a mean of 0.2 logmar, which went down to 0.0 to 0.05 logmar postoperatively. As you can see that the spherical equivalent refractive error came down from the blue region to a more around 0. And then my last point of my talk is, why not laser? We can touch up with laser when you put in premium IOLs. And I used to do that, but in these patients are 45, 50 years and older, and what do we see here? A lot of tear film problems. The break-up time in many of these cases is low, and when you touch up with LASIK, PRK, SMILE, you will end up with more severe dry eyes, and the patient will blame you because, doctor, you touched my eye, and now I have fluctuating vision, and actually I'm not so happy with it. So there are a lot of instruments on the market who can analyze it. This is an example of the HD analyzer. We can see the healthy eye, and accelerated breakup time, and of course a dry eye here on the bottom. And this nice publication tells actually the story. What gives a satisfaction rate of a patient after cataract surgery or after lens implantation, it's a reflective result, of course, but also it is the dry eye symptoms. The patient's reported visual functioning, the dry eye symptoms are more closely related with patient possibility satisfaction than with objective clinical measures of visual acuity or the signs of dry eye. So keep that in mind. And we want all our patients having a break-up time which is 10 seconds or longer. And when you don't have it before surgery, you can treat it, of course, and make sure that you don't end up with a drier eye post-implantation. Here the same, can you advance this, please? It's the same, advance the slide, yeah. So in my practice, 62% had severely abnormal non-invasive break-up time of less than 5 seconds. And the satisfaction rate 1 month after surgery was 76%. What was satisfaction rate when they had to quote out of 5? For me, 4 out of 5 or 5 out of 5 is a good satisfaction of the patient. So there is a high prevalence of dry eye symptoms after cataract surgery, almost 56%. So more than half of your patients have that. So another thing I want to talk about, and then I will conclude. So upgrade for spectacle independence with the first Q diffractive add-on lens. The indications in my practice are pseudophakic patients with monofocal capsular bag IOLs. And when I do not implant these ones with zonulopathies, of course, then centration is not always ensured. Other eye diseases such as severe macular degeneration or diabetic retinopathy. If these pathologies turn up later after surgery, it's good to have an add-on lens there because you can still explant it. So you can have a lot of opportunities and solutions now. The Liberty lens, as was pointed out by the two first speakers, and the add-on lens. One of the final slides here is this is the binocular defocus curve of the Liberty and the monocular of the first Q. And on conclusion, I can say that test all patients preoperatively on dry eye symptoms because your satisfaction rate will go on. 93%, I went from 76 previously to 93% 1 month postoperatively by not doing laser surgery touch-up but using the sulcus lens, the add-on. And this is the spherical or the multifocal you can put in those eyes to achieve our mission to have plenty of happy patients. Thank you very much for your kind attention.